Are we live?
We are live. We're just going to wait a few minutes to let our participants log on. We've got some folks joining us right now, so we'll just give them a couple of minutes to be a part of it. Well, hello, everyone. It is a pleasure to welcome you to the MedStar Washington Hospital Center Fibroid Webinar. Happy Cinco de Mayo to everyone, and welcome to this informational session regarding fibroid treatments at MedStar Washington Hospital Center. I'm your host today, and my name is Terry DeMattis. I work in the marketing department here at the hospital center. It's great to see how many people have signed up for this important topic. And before we start, I'd like to provide you with some brief background about today's speakers. But before I do, just a few housekeeping issues to cover. All of our participants are muted. If you have a question, please submit it in the Q&A box, and we will try to get all of the questions answered today after the presentation. Your questions are only seen by the host and panelists, so you do have some confidentiality. A transcript of the comments will be available throughout the broadcast and also on the video that you will receive a link to. We also have Anna with us today. She is an American Sign Language interpreter, and she will be signing today's presentation. We unfortunately had a slight change of plans with our speakers. Dr. Jim Robinson was going to speak today about minimally invasive techniques, but he was called to an emergency surgery. Luckily for us, he was able to secure one of his very able colleagues to sit in for him, and I will introduce her in just a moment. Our first speaker is Dr. Nora Tabori, and she is the Chief of Interventional Radiology at MedStar Washington Hospital Center. Dr. Tabori received her medical degree from Mount Sinai School of Medicine and completed a preliminary surgery residency with Lenox Hill Hospital in New York City. She then joined Columbia Presbyterian for a 4-year residency in radiology before completing a specialty fellowship in vascular and interventional radiology at Mount Sinai Medical Center. Dr. Tabori specializes in minimally invasive image-guided therapy for the treatment of a wide variety of conditions, including fibroids. Dr. Elizabeth Brunn, who's sitting in today for Dr. Robinson, received her medical degree from George Washington School of Medicine and completed her residency at MedStar Washington Hospital Center and Georgetown University Hospital. She is currently completing her fellowship in minimally invasive GYN surgery at MedStar Washington Hospital Center. Dr. Brunn has been involved in numerous presentations and research studies in the field of obstetrics, gynecology, and gynecological surgery. We are very much appreciative of her stepping in today for Dr. Robinson, who does send his sincere apologies. Both of these physicians are very highly accomplished with great expertise in working with patients to find the right solution to their fibroid symptoms. So now I would like to turn it over to Dr. Tabori.
Good evening, everyone. Thank you so much for joining us. And tonight, me and Dr. Brunn are going to be talking about not only what fibroid disease is, but what are the options that we have for treating it. Terry, can you advance slides for me?
Yes.
Okay, so on our agenda are fibroid basics. What are they? Who gets them? What symptoms do they cause? And then how do we treat them? We basically divide our treatment modalities into 3 basic categories. 1 is medical management, 2 is surgical management, and then 3 is interventional management. Next slide. Next slide. All right, so what are fibroids? Fibroids are benign muscular and fibrous tumors of the uterus. Now, benign, this means that they don't have a malignant process, they're not cancer, but that doesn't mean that they don't have symptoms themselves. Now, there are 5 subcategories of fibroids. We categorize them as intramural, that means that they're firmly within the muscular wall of the uterus itself. Submucosal, meaning that they're beneath the lining of the mucosa of the uterine cavity, which is what we slough every month during our menses. Subserosal, meaning that they're beneath the external lining of the uterus and protruding towards the pelvic or abdominal cavity. Pedunculated, that means they're actually extending off of the surface of that external lining of the uterus. Or pedunculated submucosal, meaning that again, they're extending into, but off of a small stalk into the uterine cavity itself. Next slide. This is a graphic explaining what I just went through. So if you see up at the top, you'll see those intramural fibroids on the left side of the screen and up towards the top of the screen, firmly implanted within the muscular wall. We have that pedunculated fibroid over to that left side of the screen, extending outside of the wall of the uterus. On the right side towards the middle, we have our pedunculated submucosal extending into the uterine cavity, and then just pure submucosal, meaning that it's underneath the lining of the uterus and partially extending into the cavity, but still implanted within the wall. And then lastly, subserosal, which is below that external surface of the uterus itself. Next slide. So back one, Terry, too many. So who gets fibroids? More than 50% of women will develop fibroids during their reproductive years. And African American women are at greater risk of developing fibroids with a higher likelihood of needing treatment, meaning that either their bulk or their bleeding symptoms will be more severe. Next slide.
I apologize for the delay with the slides. I'm having a little difficulty with my mouse. I don't know, Paul, if you're able to assist with that.
So what causes fibroid disease? The cause of fibroids is actually unknown. We know that their growth is dependent on hormones and growth factors, and that they will often change in size both with your cycle, with pregnancy, and with menopause. There are genetic links to fibroids, and they often run in families. And we don't have any effective way of preventing fibroids from developing in the first place. Next slide. So what are the symptoms of fibroids? So the most common symptom is heavy periods. In addition to that, severe menstrual cramping, which can often be debilitating or require increased amounts of medications to treat it. Pelvic or back pain can be associated with them as they can press on nerves and other structures in the area. Pelvic pressure or abdominal bloating, secondary to, again, that bulk of the fibroid being inside of the pelvis, pushing either down on the bladder, back on the rectum, or up on the intestines. Urinary frequency or urgency, again, from those fibroids pressing down on the bladder, confusing the bladder and making it think that it's full when it's not, or difficulty becoming pregnant or carrying a pregnancy because those fibroids disrupt the ability of an embryo to either implant or take up space that that embryo might need to grow in. Next slide. So I'm going to turn the talk over to Dr. Brunn now, and she's going to discuss medical management of fibroids.
Thank you so much, Dr. Tabori. You can go on to the next slide, Terry. So what I'm going to be talking about with you guys next is both medical and surgical management of fibroids. Very commonly when women come to me with symptoms of fibroids, I talk to them about all the different treatment options. And I like to make it laid out in very simple terms that we can treat the symptoms of your fibroids, whether it's heavy bleeding or pain. We can shrink your fibroids, and that can be done with an interventional radiologist for uterine fibroid embolization, or it can also be done with a gynecologist using radiofrequency ablation. That's called like the Acessa or the Asana Sonata, which I'll talk about. We can remove fibroids, and that's done via a myomectomy, or we can remove the uterus, and that is called a hysterectomy. So in terms of medical symptom treatment for heavy bleeding, there's only one FDA approved medication, and I'll talk about that next, but we very commonly can treat patients with their bleeding by regulating their periods. So that can be done with hormonal birth control pills, either combined oral contraceptive pills or progesterone only pills. An IUD, an intrauterine device, can also be used to help regulate people's periods. They've actually also found that ibuprofen, Aleve, different anti-inflammatory medications can also decrease your bleeding. So we tell patients that, the day or two before they're supposed to get their period, start taking ibuprofen. You take it on a scheduled basis, and it's found that it can make your bleeding decrease. A non-hormonal option called tranexamic acid is also another medication that can be given to patients to help decrease their bleeding significantly. In terms of history of painful periods, unfortunately, we can only treat the symptoms at the time acutely with NSAIDs or Tylenol. There is the option of using narcotics, but given the epidemic with the opioid crisis, that's not a long-term treatment option that we recommend. Next slide, please. One back, please. Oh, sorry. Okay. So let's go back to the next one. So one of the medications that can be used as a hormonal suppression is called Lupron. That is a GnRH agonist. So basically what it tells your body to do is it tells your brain to stop sending a signal to your ovaries to stop ovulating. And if you're not ovulating, then you're not going to get your period. Now, if you can imagine, though, some unwanted side effects is that you can be experiencing menopausal symptoms. So patients very commonly can get hot flashes, night sweats when they're on this medication. It does work very effectively, though, in decreasing bleeding, and it also can effectively shrink the fibroids, but it only shrinks the fibroids when this medication is in your system. So this medication is limited to only 6 months use. And when you go off the medication, then your hormones take back over, and then the fibroids can increase in size again. So it's really only used in a short-term period, and we commonly just use it in a kind of a temporizing measure when patients are getting ready for surgery. Next slide, please. So just recently, in the last year, there was a medication called Orion that was FDA approved a year ago. It's the only FDA approved medication actually that's used specifically to treat patients for their fibroids and heavy bleeding. It's a combination of a GnRH antagonist. So again, it tells your brain to stop sending a signal to the ovaries to ovulate, but it has an additional estrogen and progesterone component. So it decreases these symptoms of hot flashes and night sweats. It's also a medication that you take twice a day. So it's a pill, not a shot. So patients are much, easier to take this medication, and it has a very short half-life. So if you don't like the side effects, you stop taking the medication, and within a couple of hours, your body starts to make your hormones again, and it's out of your system. This is also approved for up to 2 years as of right now, so it's much longer use than the Lupron, and it's very well tolerated. A significantly less portion of patients discuss saying that they have those unwanted side effects of hot flashes and night sweats, about 1 in 4 in terms of patients. It's in terms of how much it decreases bleeding. So in the clinical trials that they did, it was done on a large, diverse patient population, and it decreases patients' bleeding by 85% at the 3-month mark. These women actually, in terms of their quantity, they had to have evidence of very large amount of bleeding in their periods. And then when they measured the amount of blood loss they had, it was only about 30 cc's menstrual cycle. So it very significantly improved them. 95% of patients also reported satisfaction in terms of their bleeding. So right now, this is a very good treatment option that we can use for patients that want uterine preserving, but they're not ready, that want to undergo a surgery or anything like that. Next slide, please. So in terms of, we just talked about medical management, the next option would be surgical management. Next slide, please. And what we're going to be talking about is myomectomy. So as I discussed, we can remove the fibroids, we can shrink the fibroids, or we can remove the uterus. Next slide, please. So in terms of removing fibroids, that's called a myomectomy. It can be done in multiple routes depending on the size and the location and the number of fibroids that you have. Is this considered traditionally the gold standard for women that want to preserve future fertility? Next slide, please. So the first type of myomectomy I'm going to talk about is the least invasive. It's called hysteroscopic. So basically how it works is you put a little camera in through the vagina, guide it up through the cervix, and you remove any fibroids that are going inside the uterine cavity. So there's no incisions. It's completely outpatient, and patients can have a very fast recovery. We usually tell them to just take 1 or 2 days off of work. If you can imagine though, because this is done through the vagina, we can only treat fibroids that are invading into the uterine cavity, like these images are showing on the on this PowerPoint slide. Also, there is a size limitation. If there is a fibroid that is, usually we say around 4 or 5 centimeters, so it's about like a small orange in size, at that point, the ability for us to complete that in one surgery is been minimized, and then we have to talk with patients about a different route of surgery or needing to do this surgery in staged approaches. But it's very effective in terms of treating small fibroids that are inside the uterine cavity. Next slide, please. The next type of myomectomy that I was going to talk about is the laparoscopic approach. So that is minimally invasive, small keyhole incisions that are on the abdomen. It's still done in an outpatient setting, so patients are able to go home the same day. We do recommend that they take 2 weeks off of work, so there is a longer recovery time as opposed to the hysteroscopic myomectomy. But it's not because our patients are in debilitating pain, it's just because they've had surgery and we want them to be able to take time to heal. Most patients are only on pain medication for a couple of days after surgery, and they're still able to do all their routine activities in terms of going in stairs, going on walks, cooking, that sort of thing. This surgery is our preferred route when patients have a limited number of fibroids, but they are inside the muscle or outside of the cavity of the uterus. Usually when the fibroids are less than 10, so if you're starting to have more than 10 fibroids, we're not capable to complete this in a laparoscopic approach, but when it's less than 10, it's usually something that we can do. For restrictions, we recommend no heavy lifting or anything inside the vagina for about 4 to 6 weeks. And usually we do have to recommend a cesarean delivery if you were to get pregnant in the future. And that's because we have to make an incision on the uterus. And when that incision heals, it forms a scar. Patients do commonly ask how long they have to wait after having this procedure to be able to undergo attempted pregnancy, and we recommend 3 months for the uterus to heal, and then they can attempt conception. Next slide, please. So the maximally invasive route for myomectomy is an open, and this can be done via an open incision. Usually it's a bikini cut down on the lower abdomen, like a cesarean section. And this is not our preferred route, but it is reserved for patients that usually have many fibroids and in multiple locations where we're not able to get it in a minimally invasive route. There is a longer recovery time. So rather than 2 weeks, we say usually it's about a month off from surgery. And the restrictions in terms of heavy lifting or intercourse are a little bit extended to the 8-week route. These patients also, we would recommend having a cesarean delivery if they get pregnant in the future, but their timing of how long they have to wait is still 3 months. Next slide, please. All right, so our philosophy at our practice is always to undergo the least invasive approach that will not compromise the outcome. Okay, so we always want to do what will give patients the best satisfaction, the fastest recovery, but still be able to get the outcome that they would like. Next slide, please. Lastly, for patients that no longer desire future fertility or they do not desire uterine preserving treatment options, they can undergo a hysterectomy. So, fibroids, we also counsel a patient when we remove them, we take out those fibroids, but we can never prevent new fibroids from forming. And there's actually a 25 to 50% chance of fibroids recurring within a 5-year interval. So there are many patients that end up needing to have another procedure, unfortunately, to treat their fibroids in their lifetime. So some patients opted for a more definitive route. If there's no uterus, then there's no fibroids that can grow. This is not your mother's hysterectomy, though. Traditionally, patients would get very large incisions. This is done in a minimally invasive route. And usually Dr. Robinson does not have a uterine size where he says this uterus is too large to be able to do in a minimally invasive fashion. So it means small keyhole incisions. It means 95% of our patients are able to go home the same day. It means that they're only on pain medication for a couple of days, and most of them have pretty high satisfaction and are able to go back to doing their routine functions within a day or two. And traditionally, for your mother's hysterectomy, they would remove your ovaries. You would go into immediate menopause. We know that the ovaries, even if you've gone through menopause already, have benefits: bone health, skin health, cardiac health. So we preserve the ovaries at least until the age of 65, so you do not go through menopause. We also preserve the vaginal length, so there's no effect in terms of sexual function as well. And there has been previously in the older type of hysterectomies that were done in very large incisions, they would take some of the pelvic support structures that would increase women's risk for pelvic organ prolapse. And we do not do that either. We preserve all of the ligaments within the pelvis so that you're not at increased risk for developing prolapse in the future. Next slide, please. So I believe actually I kind of already discussed this, but this is a visual in terms of showing how the laparoscopic hysterectomy occurs. We generally do 4 tiny incisions that are only 5 millimeters in size, so that's about the width of my pinky finger. And one of them we usually go through the belly button, so it's hidden. It's very cosmetic. In terms of returning to work, it's about a 2-week recovery period. And the biggest benefit of this is it's really the only definitive treatment that there's no risk of fibroids recurring, so you're really minimizing any possibility for any future surgeries. Next slide, please. Now, I briefly earlier talked about the option of you can remove your fibroids, you can remove the uterus, but you can also shrink fibroids. And Dr. Tabori is going to talk about this in detail in terms of the interventional radiologist portion where you can do uterine fibroid embolizations. And those have been approved since the 1990s. But in the last couple of years, there has been some new techniques that have undergone from the gynecologic setting where we can shrink fibroids as well. And there are 3 FDA approved techniques. One is the Exablate, that is MRI guided focused ultrasonic surgery. There's the Acessa, which is a laparoscopic approach for radiofrequency fibroid ablation. And lastly, there's the Sonata, which is a transcervical radiofrequency fibroid ablation. And we have the Sonata available at our downtown Lafayette Outpatient Center through MedStar. And we're currently the only facility in the DC area that is providing this. Next slide, please. So I wanted to talk a little bit more about the Sonata. So it was FDA approved back in February 2020. It is a great treatment option for women that want to have a uterine preserving treatment option for shrinking their fibroids. There are no incisions. It's completely outpatient. They go home same day. And the recovery period is very fast. It's usually only 1 or 2 days. In terms of pain, we tell patient all they need usually is just ibuprofen and Tylenol, and patients really have minimal discomfort. The Sonata is approved for up to 5-centimeter fibroids, and it's approved for all fibroids inside the muscle, those that kind of stick inside the uterine cavity, stick outside the uterine cavity. The only ones it's not approved for was what Dr. Tabori was saying was the pedunculated, which means that they're just sticking completely either outside of the uterine cavity or completely inside the uterine cavity. And while it is FDA approved for 5 centimeters in size for fibroids, we are able to go up to 7 or 8 centimeters for patients. We just have to counsel them that they might have decreased effectiveness. Patients usually, in terms of what it does, is it shrinks their fibroids 60% in volume over the course of the year, and the fibroids get significantly softer. And they usually report within 1 month a significant decrease in their bleeding symptoms as well. Next slide, please. So I'm going to hand it back over to Dr. Tabori now.
Hello again, everyone. So now I'm going to discuss the interventional management of fibroids, also known as uterine artery embolization or uterine fibroid embolization. Next slide, please. So what is UAE? UAE is a minimally invasive catheter-based therapy where the blood supply to the fibroid is blocked or embolized. So what that means for you is that we're able to access an artery either down in the groin, known as the femoral artery, or up in the wrist, known as the radial artery. And then we snake a small catheter, which is basically just a long, flexible IV, down to the level of the uterine artery. And then we inject a type of bead or embolic agent to block up the actual blood supply to the fibroid itself. Now, when you block the blood supply to something, that will deprive it of nutrients and oxygen. When any part of the body is deprived of nutrients and oxygen, it starts to die off and shrink. Now, the reduction in size that we tend to achieve over about a 6-month period of time is somewhere between 50 and 60%. But there's an immediate softening of the fibroids once we've cut off that blood supply. And I like to make the analogy of something similar to a water balloon on a tap. Now, when the water balloon is connected to the tap, it's taut and it's firm. But the second that you take it off that tap and you tie it off, if you just let it sit overnight, it'll start to soften and dimple. And the exact same thing happens with a fibroid. Within 24 hours, patients start to realize that they feel a decrease in the amount of pelvic pressure and fullness inside of their abdomen and a softening of their abdominal compartment. And they start to notice that their bleeding symptoms will come off. Now, that reduction in blood flow to the fibroid prevents those future bleeding symptoms from coming back. And then that shrinkage helps us with those bulk symptoms such as pelvic pain, back pain, bloating, and urinary frequency. Next slide. This is just a pictographic image of what an embolization would look like. And as you can see, we sort of use this long IV that goes up through the artery, identifies the uterine artery, and then the specific branches to the fibroid. And as we inject those beads, the fibroids actually sump the blood flow of the entire uterus towards themselves. And so they end up taking the majority of that embolic agent towards themselves and sparing the blood supply to the remainder of the uterus. Next slide. These are actual images from a fibroid embolization. And as you can see, we have catheters in place. And initially what you see is these large, thick serpiginous arteries going up to this large, bulky central fibroid inside of the uterine cavity. And then at the end of the embolization, all you see is the sparing of the parent arteries, but those small branches are all gone. And if we go to the next slide, we'll see what that does in terms of the fibroid over time. So as you can see in the baseline, in the center of that screen, you see the uterus. To the right side of the screen, you'll see the spine at the superior margin of it. And on the left side of the screen, you'll see the anterior abdominal wall. And in that central portion of that baseline, you see our large, bulky fibroid that's extending towards the uterine cavity. Now, at 3 months, what we see is all of that sort of heterogeneous tissue has now become black on that arterial enhancement phase, meaning that it no longer has a blood supply. It's not filling and it can't have any contrast go towards it. And then as we move forward and progress to 1 year, 2 years, 3 years, and 4 years, you see everything shrink down. And ultimately by 4 years, there's no residual evidence of that fibroid whatsoever. The uterus has returned to its normal size. That bright white structure that you see sitting underneath the uterus, that's the bladder. And you can see how much more space that bladder has, how much more space the rectum, which is that black structure posterior to the uterus, has. And that's why we see that reduction in bulk symptoms and then reduction in bleeding because that blood supply is gone. Next slide. 80 to 90% of patients will have improvement in their symptoms by 3 months of treatment. Additional fibroid treatment will occur in about 7% of patients at 1 year, 11% of patients at 2 years, 14% at 3 years, and up to 20% at 5 years. And again, as Dr. Brunn was saying, in the absence of removing the uterus, recurrent fibroid disease occurs right around that 5 to 7 year mark, because that's sort of the natural history of the time it takes for a new fibroid to grow. And that's why we have that up spike at about 5 years. There are similar recurrence rates inside of the myomectomy data. Next slide. So what do you expect during your recovery period, right? Because part of what choosing the right treatment for your fibroids is not only your symptoms, but then what your recovery period is going to be. We tend to tell people that they're going to be in moderate, but really I would say moderate to severe pain for about 4 to 6 hours after the procedure, which we treat with opioids for about the first 24 hours. On a scale of 1 to 10, the average patient says their pain rates between a 4 and a 5. This is an outpatient procedure, so you're discharged the same day. You can expect to have cramps for about 2 to 3 days. And when I say cramps, I mean real cramps. These will feel a little bit like the beginning of labor pains. It is an intense cramping sensation. And fatigue for 5 to 6 days. And that fatigue is just the natural reaction to any embolization in the body. When the body realizes that something inside of it has had its blood supply cut off, it's going to activate your immune system to go in, clear out that tissue that's dying off and turn it into scar tissue. But that activation of the immune system requires energy the way that anything does, and it can cause some fatigue. There's really no limitation on your physical activity 48 hours after the procedure. And in the first 48 hours, the only real limitation on your physical activity is please don't run a marathon or join a weightlifting contest, but normal activities like walking around the neighborhood, cooking dinner, things like that are all totally allowed. Most women will return to work 7 to 10 days after the procedure. The reality is most of the women that I know go back after about 3 to 4 days, but we recommend 7 to 10 days just to give you that extra buffer of time in case that fatigue is just kind of wearing you down and making you not quite as prepared to be back at work as you might like to be. Next slide. So now Dr. Brunn and I are going to discuss what treatments are right for you. And we're going to base that off of any questions that you guys might have for us, because again, I imagine that a lot of you are trying to figure out which one of these treatments would be the right thing for you.
All right, well, we do have some good questions here from our participants. The first question relates to a patient who received an ultrasound report listed as a mid-body fibroid. And is that the same as an intramural?
Yes, yeah, usually.
Okay. Also, we have a question where someone was told that once they stop their menstrual cycle, the fibroids will automatically shrink because there's no longer a blood flow to them. This person is over in age 66 and the fibroids have not shrunk at all. And she suffered with symptoms with the exception of some pregnancy problems. She feels that her belly looks like she's pregnant and she wonders what she should do.
Yeah, so after menopause, the reality is for many women, fibroids will shrink down because they are hormonally regulated. And then also the blood supply towards the uterus in a hormonally regulated way will decrease after menopause. And so many women will experience shrinkage, but that does not mean all of the fibroids will disappear. And we often see women who still have bulk disease past menopause. And then the question becomes, what is the right treatment for you? Now, I think it kind of depends on the size and the location and also the permanence of what you're looking for. You're unlikely to develop new fibroids at this point because whatever hormones regulate their growth are unlikely to be present after menopause. So I think sort of any and all of the treatments are on the table, but the most definitive and also depending on the size of your fibroids would be a hysterectomy. And after menopause, hysterectomy is often what we recommend, or at least what I tend to recommend at least a consultation for when I have someone coming into the office to discuss embolization. Dr. Brunn, what are your thoughts?
Yeah, no, I agree with everything that you said. Hysterectomy is certainly, an option, but there are a lot of women, even though they've gone through menopause and they don't desire future fertility, they would desire a uterine preserving treatment option. And it really does depend on the size and location. And then I just also want to, piggyback and say that fibroids are benign, they're not cancerous, but they should not be growing, or new ones really shouldn't be forming after menopause. So if that is happening, where there's rapid growth of fibroids after menopause, we always also want to evaluate and make sure there isn't any concerns for cancer as well. And that would be called leiomyosarcoma.
Okay. What are your recommendations when a woman is beyond childbearing age, but is opposed to hysterectomy, but would like to preserve her uterus?
Yeah, so exactly. There are plenty of uterine preserving treatment options. There are many women that desire to preserve their uterus, even though they don't desire future fertility. And so those were the ones that we talked about: the shrinkage of the fibroids, either a uterine artery embolization or the Sonata procedure, depending on the number of fibroids and the size and location. And also myomectomy is still an option as well for patients, but that one has a longer recover period and has a higher morbidity. So it's taken on a more case by case basis when you're postmenopausal.
All right. Could you explain a bit more about the recommendation for a C-section after laparoscopic myectomy?
Absolutely. So it's not always. It depends on the amount of myometrial defect that occurs during the surgery. So say there is a fibroid that's just sitting off the top of your uterus and it's not really involved in the muscle at all. If we were to remove that laparoscopically, you absolutely could try and have a vaginal delivery. The concern that we have is that if we make a large defect in the muscle of the uterus, when that muscle heals, it forms a scar, and it doesn't function like the muscle normally does when the uterus contracts. So when you become pregnant, if you were to go into labor, the concern is that that muscle, the uterus, could potentially break open during labor, and that's called an abruption, uterine rupture, sorry. We don't have great data on the number, but we do know that patients who have a cesarean section where there's a large defect on the muscle of the uterus have a 10% risk of uterine rupture if they were to go into labor. So we do extrapolate that number and believe that the number is probably similar. And that's why we make that recommendation for a cesarean section if there is a large uterine defect that's made during the surgery.
All right. Is there any dietary research on preventing the occurrence or growth of fibroids?
I know a little bit. Dr. Tabori, do you?
I know a little bit, but
Yeah. Yeah, so unfortunately, it's not, there isn't good evidence for it. There's, we always recommend being, healthy and fit, exercising, controlling your weight. We do know that obesity has a correlation with fibroids. There has been a study that shows, like decreased caffeine and alcohol intake, but it's really not clinically significant at all. So unfortunately, we don't have any, I at least don't have any recommendation on certain foods that you can avoid that'll certainly won't shrink fibroids.
Okay. Could you clarify if fertility is maintained with the Sonata, and also is it maintained with UFE?
Yeah, absolutely. I can talk about both of those, and then I'm sure Dr. Tabori can also add in about the uterine fibroid embolization. So right now for the Sonata, because it's only approved a year ago, they cannot make an FDA recommendation on future fertility. Now, I know that there are certainly patients that have gotten pregnant, but it's a small number, less than 100. Of those women that did get pregnant, there was absolutely no decreased risk of miscarriage or complications in the pregnancy. But at this time, because it's so new, they can't make a recommendation. So it's just as a uterine preservation option. So we kind of say it's possible, but it's not, it's kind of off label. For the uterine fibroid embolization, there are studies that have been done. So patients are certainly able to get pregnant as well afterwards. At Washington Hospital Center, they recommend waiting 1 year before trying to conceive. There is unfortunately not very good randomized control trials. So that means where you're randomizing a patient to either getting a myomectomy or the uterine fibroid embolization. So most of our studies are retrospective. So that means these are patients that are getting pregnant, and then we're looking back to see was there increased risk for complications. And I believe that when they compared myomectomy to the uterine fibroid embolization, the myomectomy did have a slightly higher fertility rate, but they do absolutely are able to get pregnant after a fibroid embolization as well. Dr. Tabore, was that correct?
Yeah, that is correct. So, what Dr. Brun was saying is, everything that we're doing is we're collating data from patients that we already have, and we're trying to age match them and match their medical history and see if we can find a cohort of patients that are similar that we can sort of analyze for, were they able to get pregnant? And then can we compare them to the same type of patient that was in the myomectomy group? And there have been what we call meta-analyses, where they take multiple of these retrospective studies and they collate all the data together, and then they try to look at it from a much larger multi-institutional level. And on that institutional level, there is a small blip in signal to say that there was a higher rate of fertility in the patients that got myomectomy than they were in the patients that got embolization, but fertility is still preserved after embolization. The one thing that we do say is that we don't recommend that you get pregnant within 1 year of the embolization. And the reason why is because initially after the embolization, and if you think back to those pictures that I was showing you, the fibroid and the normal uterine tissue, they share a blood supply. And the fibroid is basically like a greedy kid at the table and sucks up as much of the blood supply as possible, which means when you embolize, it also sucks up the majority of the embolic agent, and it spares the normal uterine arteries. But small amounts of the embolic agent will go throughout the uterus. That will resorb over the course of several months. So we give it time in order to make sure that the entire normal uterine blood supply is completely restored before we recommend pregnancy. Now, that being said, I have had patients get pregnant within 4 weeks of getting an embolization, and they go on to have healthy pregnancies. I do not recommend this. This is the opposite of the advice that I give in the office, but nonetheless, anecdotally, all of us see this on a regular basis, whether they go on 1 month, 3 months, 6 months, 2 years later to get pregnant. We have happy, healthy pregnancies all the time following embolization.
All right, here's another question relating to embolization. What are the beads made of?
Yeah, so they're made of something called triacyl polymer mixed with a gelatin slurry. So the gelatin slurry is basically something very similar to what your cartilage is made of. And it's also partially comprised of the clotting factors that you naturally make in your body. This is part of why these beads will aggregate together and form a clot. In addition to that, there is a sort of a polyvinyl ethanol component to it, which is a dissolvable polymer of ethanol. And that allows it to actually take its form. And so the bead itself is roughly the size of 1 to 300 microns, which is about the size of a speck of dust. But when you put them together, they aggregate enough to fill up the capillary level of the fibroid.
Is there any research on the occurrence of fibroids after a chemical abortion?
I'm going to leave that to Dr. Brun. I don't know.
I'm not sure if I understand the question. So if that person could maybe clarify, like, are fibroids causing miscarriages, or are they asking, are fibroids occurring after a miscarriage occurs?
All right, if the person who submitted that question maybe wants to submit it in the chat, or we can try to get back to you. I have a question relating to, will Aurion shrink the fibroids?
Yeah, so they did study this, and for those patients that were, their primary outcome for the study was to find if there was decreased bleeding, which it met that criteria. There was a secondary outcome that they wanted to see if it would shrink fibroids. And basically, when I looked at the studies, they did find some small decrease in size, but it was not statistically significant or clinically significant. So you cannot anticipate that there'll be a decrease in your bulk symptoms when you take this medication. The medication Lupron, which was the shot, that has been shown shown to decrease fibroid size, but only while you're taking the medication. As soon as you go off of it, it will return back to its original size.
All right. If a patient had the embolization in 2018 and still has heavy menstrual cycles lasting up to 15 days, what would be the next best option for someone like that?
So a lot of times when there is a failure in embolization, it can be that there is a secondary blood supply to the fibroids. Now, when we talk about our arterial blood supply in our bodies, we have all these named arteries. We have the uterine arteries, the ovarian arteries, the renal arteries, a specific artery that goes to one organ. But our body is very smart and it has a backup system for every arterial supply. So often that backup system is the neighbor. And so in the uterus, if the uterus is close to the ovaries, a lot of times there is ovarian supply to fibroids as well. And so one, you can repeat the embolization, specifically looking for ovarian supply. Two, I would repeat the imaging to make sure that there isn't a component of something that we call adenomyosis. Adenomyosis is a little bit different than fibroids. Adenomyosis is an abnormal location of normal endometrial tissue within the muscular wall, and it causes increased bleeding. Now, adenomyosis is effectively treated by embolization, but that embolization's permanence only lasts for about 1 to 2 years. And so I think before I would recommend any treatment, I would recommend repeating the MRI to make sure that we are really dealing with bleeding from fibroids. And then if a second embolization was desired, then I think that's always a possibility. We tend to do a minimum of 2 before we would call it a failure. But we would also offer additional options depending on the size and the location, such as Sonata, myomectomy, hysterectomy, and that would be more of something that Dr. Brunn would be able to talk about.
Is there for the laparoscopic myectomy, are the fibroids removed through the belly incisions or the vagina?
Oh, that's also a wonderful question. It can be through both. So basically what we do is after we remove the fibroids, we put them in a containment bag, and people are always like, so how do you get because sometimes the fibroid can be as big as a watermelon. How can you get a watermelon out of something the size of, only an inch or 2? And what we do is we put the fibroids in a containment bag, and we then extend one of our incisions. That could be the belly button. It could be an incision that's down by the bikini line, or it could even be through the vagina. And then we bring the fibroids in that bag up to the level of the incision, and then we remove the fibroids in a hand coring technique. Now, there's previously been concerns about morcellation. You might have heard that is a black box that was using a machine that would grind up and morcellate the fibroids. And as it would do that, it could spread little cells of the fibroids throughout the abdomen. And there could be concern that if there's ever any concern for cancer, then those abnormal cells are being seeded throughout the abdomen. Now, because we put all the fibroids in a containment bag and we hand morcellate them, so we take them out in small pieces, in the very unlikely event, if there was any abnormal cells, it would be contained within that bag and not seeded throughout the abdomen.
All right, we have some questions relating to the beads that are used in the embolization, if they can spread to another part of the body, perhaps causing loss of blood flow or create any other issues.
Yeah, so during the process of embolization, we actually directly visualize. So we mix the beads with what we call X-ray contrast. So we can see it on our fluoroscopy. So as we're injecting the beads, they're flowing into the body mixed with contrast that we can visualize. And we visualize that forward flow of contrast into the fibroid tissue. And when we no longer see this fast forward flow towards the fibroid tissue, we stop. Now, is there the possibility of what we call reflux? Yes, there is the possibility. But part of the reason that we use this continuous visualization is to prevent that from happening. Now, as I was describing before, we sort of have these connections between the arterial supply of one organ with the adjacent organ. So initially, when we go in and we take pictures of the uterine artery, one of the things that we're going to specifically identify is whether or not we see flow towards one of the ovaries, down towards the vagina, or over towards the cervix. If we see flow towards one of those other organs, we'll either bypass the branches that are going towards that other organ by just simply advancing the catheter past that location and embolizing distal to there. Or if need be, we'll go in and place something called a coil, which is a short segment plug that basically plugs up that connection and would prevent beads from being able to travel from the uterine artery over to, say, the ovary or the vagina. Very rarely do we need to use these plugs. Normally, we can just bypass those anastomotic branches or those connections between the organs and get our catheter distal to that location and then embolize from there. And then again, we very carefully monitor for reflux to make sure that those beads are not backing up and going towards an artery that we don't want them to go to.
Is there a procedure that stands out in terms of giving someone a decent chance to conceive?
I think that with all of them, there is a reasonable chance of conception other than obviously hysterectomy. Again, I think it really depends on how soon you're looking to conceive. I think it depends on the bulk of your fibroid disease, where your fibroids are located. And, there are a variety of other factors that go into fertility that are associated, that go into fertility periods, such as your hormone levels and your ovarian reserve. And that's a whole other question that, is sometimes separate from the fibroids. Is it the fibroid that's causing the issue? Is it a mixture of, other underlying fertility issues combined with the fibroids? But I think that the chance for fertility is very much there for all of the procedures other than hysterectomy. Dr. Brunn?
Yeah, no, I completely agree. I think that's the main reason why we counsel our patients that there's always more than one option, and it is what your goals are in terms of whether it's fertility or symptoms. And that's why we always have a conversation to kind of meet what your goals are and then the best outcomes.
I don't know if you guys can speak to this, but there's some questions relating to insurance coverage. And, if insurance companies tend to want less invasive treatments to be tried first, what can you advise in terms of knowledge relating to insurance coverage in these procedures?
Unfortunately, my knowledge is going to be somewhat limited. I can't say that I've ever known anyone from getting denied from having a uterine artery embolization. And I'm not sure if Dr. Brunn would have more information about myomectomy versus hysterectomy versus laparoscopic versus Sonata. But for the most part, I believe that fibroids as an overall pathology are a well understood and covered entity by insurance.
Yeah, absolutely. I will also say that I will have limited knowledge, but I've never experienced a patient being denied by insurance to be able to have the procedure of their choice. The only times there can be some issues is actually more in the medical management. Sometimes we'll prescribe a combined oral contraceptive pill, and an insurance company will want us to try a different medication before going to this one. But in terms of the surgery and the treatment options, I've never experienced any issues.
Okay. In terms of embolization, how long does it take for the fibroid to pass through the body? And is there any infection or risk of infection or odor?
Yeah, so the fibroid doesn't actually pass through the body. So depending on whether it is, in the case of submucosal fibroids, the ones that are underneath the lining of the uterus, sometimes partial passage of the tissue will occur. And certainly if there is a pedunculated fibroid, the whole fibroid can occasionally pass. But for the most part, what ends up happening is as the fibroid's blood supply is cut off, the cells within the fibroid begin to necrose and they liquefy. And then the immune system comes in and converts those cells essentially into a scar tissue, a piece of scar. That process usually takes at least 6 months to complete, but it can take a little bit longer than that. In terms of infection, the closer the fibroid is to the uterine cavity, so the more it extends into the submucosal space, the more likely there is to be something for it to get super infected. Now, when we think about it, our uterus is connected to our cervix, or I should say our endometrial canal is connected to our cervix, is connected to our vagina, which is connected to the outside world. So this is not an entirely sterile system that we are working with. And when you cut the blood supply off to something and that tissue starts to die, it can be more permeable to bacteria. That being said, I have been doing this for 7 years and I've never had anyone get a single infection during that time. So the incidence is extraordinarily low, and I probably do at least 100 of these a year. In terms of the odor, as you pass tissue, it can have a different odor. The most common thing to happen as a fibroid is liquefying, though, is for you to get a clear discharge. A lot of women will come back and say, I think I developed a small amount of incontinence after the embolization. And, we tell women to wear panty liners pretty much 24 hours a day for the first at least month and up to 3 months afterwards. And that's really to deal with any of that clear discharge that might happen. It should not have an odor to it. If it does, then we would recommend a short course of antibiotics. Sometimes any procedure involving the GYN system can slightly change the pH balance of the vagina, and you can be more prone to either a yeast infection or to something called bacterial vaginitis or BV. A BV can have a smell to it, and we can give you a short course of metronidazole. Again, that's just a change in the pH of your system based on any procedure being done. But true infection, what we would call ascending endometritis, from an embolization is something that I've read about, but I've never actually seen. And I'm a pretty high volume performer of these procedures, but that sort of clear discharge, that I do hear about on a somewhat frequent basis, and it usually lasts for about a month or so.
All right. Here's a question related to surgery. Does hysteroscopic myectomy increase the chances of cesarean, and can it result in scarring?
Absolutely great question. So because there is no incisions that are made on the actual uterus, what we do is we put a little instrument in through the cervix into the uterine cavity, and we kind of shave off the fibroid that way within the cavity. There's no incisions that are made, so the myometrium, the muscle of your uterus, is preserved, and you can absolutely try to have a vaginal delivery in the future. What was the second part of that question?
If it could lead to scarring?
So anytime a procedure is done for any type of surgery, one of the subsequent effects of it is that your body likes to form a scar. So if you do a hysteroscopic myomectomy, scarring can happen inside the uterine cavity as it's healing. But we have lots of tips and tricks of ways that we can minimize this. One thing that we like to do is we like to bring patients back in a couple months after they've had their myomectomy to look in the office, and we are able to do office hysteroscopy. So patients are completely awake, they tolerate it very well, and we just take a quick look inside the uterine cavity to see if there's any scarring. The thing about scarring is it takes time for it to become firm. So when it's caught early, we can very easily treat it and break up scarring to maintain the shape and normal contour of the uterine cavity.
Okay, well, we have time for just one more question. And this is a very interesting one. Can fibroids impact your weight?
Okay, so your weight can certainly impact fibroids. There is some evidence to say that there is a link between obesity and number of fibroids. Now, can fibroids impact your weight? Yes, they themselves will weigh something, but let's say we're not talking about the actual density of the fibroid. I would say, as a human being, more than a doctor, the way that fibroids affect people's weight is that they affect your comfort in your own body. If you are constantly having pelvic pain with movement, if you are having heavy bleeding such that it's uncomfortable to exercise because you are concerned that you are going to bleed through your workout clothes at the gym, these are the types of ways that fibroids, I think, meaningfully impact someone's weight, because they reduce your freedom in your own body and your ability to participate in exercise in a healthy and active way. And I don't know if Dr. Brun feels
Yeah.
similarly or, has anything to add to that, but that's really where I think that fibroids impact not only our self-esteem, but our true physical self, is that they can limit a woman's ability to go out into the world and to participate in things, because you are concerned about all of these factors that they impact, such as your urinary frequency, bleeding through your clothing, pain inside of your body just constantly.
Yeah, absolutely. It really does affect your quality of life. I have patients every day that have exactly what you were describing, Dr. Tabori. And also, though, in addition, if you think about it, fibroids are in your pelvis, so it's going to affect your disproportionately in terms of location of increased bloating and girth in your abdomen. So there's some women that are like, I am an avid runner. I can bench press 150 pounds, but I cannot get the six pack. And it's, because there is a large bulk that's happening inside their abdomen. And when we remove the fibroids or undergo a hysterectomy, I have had women that drop a few pant sizes, just from undergoing the surgery. So, fibroids, they do have a weight, but it's not like you don't drop 20 pounds. It can be more like you drop 1 to 3 pounds, but it's because they take up so much space that they really affect the abdomen.
All right, well, thank you, Dr. Brun and Dr. Tabori, for this very informative presentation. Thank you, Anna, for doing our interpretation today. I'd like to thank everyone for joining us and the great questions that you have submitted. Tomorrow, you're going to receive an email that will have a link that will include a video of today's presentation, as well as a short survey that we hope you will take the time to fill out. It's only 5 questions. It only takes a few minutes, and so we would really very much value your feedback. Again, thank you, everyone. It was a great session, and we look forward to sharing more health information with you in the future. Thank you.
Bye, everyone. Thanks.
Thank you, everyone. So nice to meet you virtually.
Yep, you too.